Well, look, ACLs, it's no secret, everyone loves it. It is literally one of the most studied topics in orthopaedics. I had a quick PubMed check and you've got over 40,000 papers on it. And a lot of it in the last decade, basically. Everyone wants to talk about it. It is becoming a very common operation. You know, it's increased 12-fold over the last 20 years. And you'll also notice it's been quite, big thing in the public domain. Huge media publication on it about injuries with women, athletes, and kids, and also still an exam topic worthy, so it's worth knowing all about it. And obviously you've got practical to learn about, so we'll try and go through a bit of my experience. So anatomy, everyone loves anatomy with it. I mean, I've said it here, but there are two bundles. Okay, you've got the AM bundle and the PM bundle. Now, they call those bundles based on the relationship of where they insert on the tibia, okay? What's special about the ACL? Why can't we reproduce the ACL the same way with our hamstring, the BTB, as we can here? What's special about it?
Bundles react.
Twists.
Sorry?
The bundles react differently.
That's one thing, yeah.
And twists, and then
It twists as
they
well,
have
yeah.
different tensions.
And the third thing that we can't reproduce as well?
It's got proprioception fibers.
Yeah, it's got mechanoreceptors. So all of those things combined make the ACL such a beautiful substance because we can never recreate this broad cylindrical structure that starts at the back of the femur, rotates all the way around in unison to then insert near the tibial spine. And as Abby said, it's got different bundles do different things, for example. So your AM bundle, it's very important when it comes to flexion because it becomes very tight. Whereas an extension, your PL bundle goes and gets very tacked. When's that something that you embark on examination? Okay, part one question. Pivot shift, they say you're testing the PL bundle technically because that's where it ends up getting tight in those areas. And then most studies have also shown that any fibers that are very close to the footprint near the ridge are the most important one when it comes to stability and isometry as well. So it's so important that we understand the anatomy to then recreate how we're going to reconstruct the ACL going down the line. I'll put some basic science in here as well if you understand how ligaments work. Can anyone describe this curve to me? What's going on here? On there for you.
Stress strain curve of the ligament. One thing to note is the toe region at the beginning, which represents it's a linear elastic region until it reaches its heel point and has failure.
Perfect. So this is a bit different to metals, right? Or organic materials. They have that up and down shape. You get the whole necking point with it. You don't get that in ligaments. When they go, they just snap completely with it. And that's what happens because all the fibers are getting ripped all together. These insertion points, the different zones, whether you've got an indirect insertion or direct insertion, and that's how ligaments attach. I won't go into too much detail about this, but do you all understand what viscoelasticity is? I see. What's viscoelasticity?
Is it the material's property to resist strain and
Yes, answer. Who else? Who's in the exam again? I forgot. Mark.
Yeah,
go on.
viscoelasticity represents four characteristics of a property that demonstrates this. There is hysteresis, stress relaxation, time-dependent. I can't remember the fourth.
We're nearly there. So one of them is hysteresis, which the bad thing about it is you've got creep, stress relaxation, hysteresis, and then time-dependent deformation. So depending on, it's all to do with Play-Doh. Okay, if you have kids, you know what Play-Doh is like. If you stretch, the fourth characteristic about time-dependent deformation, if you have Play-Doh and you stretch it really slowly, it stretches out slowly. If you rip it quickly, it rips. That's one definition of it. Do you know what that creep, stress relaxation is? I can't remember the definition of FRCS, but it's definitely worth remembering because I always bring it up every time again and again when it comes to the exam. It's the one thing you must be able to draw is draw all four graphs when you get talked about a viscoelastic substance, and ligaments are classic for that. We know that people get ACLs more commonly than the others. And the big hit at the moment is the fact that we're noticing it more in women, okay? They've got an odds ratio of 1.5 higher than getting it in men. Kids are also double likely getting it, as you heard from Mr. Gupte. But what are the reasons behind it? You know, some people oppose that it's to do with hormonal things. Some people oppose it's to do with anatomy differences. Women have got slightly different pelvic tilt, a lot more bit of valgus. They've got increased slope potentially, smaller notches. But actually, what we're realizing is they are more common. But why are we noticing it more often? It's because we're actually giving women the platform to play sport. We're now watching them more on TV. We're giving them more equipment to see that they actually are getting more ACL injuries. They always were. We just didn't notice it. And you speak to Andy Williams about this, his philosophy is that the reason that they think women are getting more ACL injuries is because there is still a very sexist behaviour when it comes to prioritising men versus women when it comes to football pitches. My friend Sarah Bolton went to Barcelona and she noticed that the women's A team play in the same pitch as the C team for the Barcelona kids. And that's how the things start off. They get the worst equipment, they get training later. If you're an 8-year-old in the academy of Liverpool, you are given the best stuff, the best physio, the best gyms, whereas women don't get until like 12, 13 years old. So some of it's to do with that potentially. You've then got extrinsic type of things as well, different sport or footwear. And all of this has driven the fact that basket's taking more of an interest in this now, and also big projects in start called Project ACL, which is going to be a big study into funding how we're going to try and prevent this from happening and try to look after people in sport. So whenever you get asked to examine somebody or to assess somebody, it's triple assessment. That's for most things. History, examination, investigations. History is so important, okay? And a nice interesting thing that Mr. Gupta said earlier was about when you see a patient come to clinic, it's always worth reading the GP letter and nothing else. Because 8 out of 10 times, you should know what's going wrong with that patient. And they will give you these clues about it. I was playing football the other day, I twisted awkwardly and I just fell down. My knee swelled up straight away, I had a pop, and ever since then I just don't trust my knee. That is easily banged or either ACL or ligament injury or a PFJ dislocation potentially. Okay, that is almost a barn door situation that you're going to get in with it. You all know who this guy is? Michael Owen. Yeah, very famous ACL injury because he obviously went down during the Euros, I think. Examine the patient. This is when, so a lot of the time when I've examined the patient, I tell them immediately what's wrong with them because I know they've got an ACL injury based on the history and the examination. And the MRI scan is only to confirm my diagnosis, but also look for other chondral or meniscus injury. Now, contrary to popular belief, you can pivot a patient in clinic. Okay, if you do it properly and you relax them and you sneak up on them with it, you can do it. I have only not pivoted one patient in the last 12 months as a consultant, and that's only because he was really rigid. I brought him back 2 weeks later. Did it again, and I pivoted them again with it. So you can pivot them in clinic. It's a misnomer to think you can't do it. How does the pivot work, Esther? I'll show you quickly while you think of your answer and frame it for me. But this is a pivot here. No, not that one. One of the best ones I've seen, so I've recorded it. So tell me what's happening there.
So you bring in the patient into
And
adduction, and you're reducing the.
so at the moment, so you start off how? Internal rotation.
Yeah.
And adduction or
Valgus.
valgus, yeah. And then what's happening there? You flex the knee up.
The plateau is originally
Sublux, yeah.
Yeah, and you're reducing it with that.
IT band. So IT band is pushing it back down. So what's happening? What does the IT band normally do? Someone say it. You whispered it. It's a knee extensor, right? Okay. As you flex that knee, the IT band slides back from this center of rotation, becomes a knee flexor. It pulls that knee back. So, like I said earlier, the knee is subluxed to begin with. So you're actually subluxing the knee like that, and then as you're flexing it, the IT band pulls it back down again, and that is how the knee reduces itself. So you need to have what? An intact IT band. What else? Intact MCL and a torn ACL as well. You must always examine the normal side first, okay? And that's because you may get caught out with other injuries they may also have if they're very lax. There's a guy, what we're doing here. Here a draw. Yeah. Who gets taught to examine collaterals up in their elbow like that? How do you guys examine it? Do you examine like this, or do you examine it with the leg and the elbows and do it side to side? Why do you do it that way?
I went to George's, we didn't get taught.
Okay, why have I examined
It's true.
Why is it important to examine it the way I examined it there with the knee down on the ground? Anyone?
Try to eliminate, obviously, hip rotation.
That's one thing, but most importantly, we're knee surgeons, we're not hip surgeons.
They are taught in extension.
If you bring the knee up and your ACL is lax, your knee tibia slides forward, okay? If you test collaterals from side to side, you've got a false tension of the MCL and the LCL because then you've got a longer distance for the MCL to travel with the LCL. So you may get, if you've got a torn MCL, you may get a false reading. By bringing the femur back up again, you're reducing that tibia where it should be, so you've got normal tension. And then you can test the capital intact. And that's why, with the multi-legs, I would do the cruciates first, get the knee under the femur, and then do the collaterals afterwards, because then they will be tensed by whatever total tension I'm doing with the cruciates. Who can tell me what's going on in this picture here? So this is the way that Andy does it, okay? You must do it, if you're going to do it supine the way you do it, you must look down to see how the foot is being increased, whether it's in 30 degrees or 90 degrees. And you can see here a very obvious dial test on the left-hand side here. And it's also important to see, like I mentioned earlier, it can either be due to posterolateral instability or anteromedial, because the tibia, like we talked about earlier, can go around the front or loop on the back. That's why it's easy to see it this way around. So you need tibial to do this. And the way that Andy always teaches you is to make sure you lock the foot up and you both have the heels together, the knees together, and then externally rotate it. What's going on over here? What does that mean? Don? Have you seen the have you seen the LCL? It's like this small, it's absolutely tiny. So it's the whole structure that's gone normally, isn't it? What's that? What's the corner with it? And I did have a video of a thing, but I wouldn't show the video here. Yeah, annoyingly. Be aware of the missed PLC injury. It's the commonly missed injury that you see on examination. People miss it all the time. And Pete Thompson always goes on about this. If you don't look for it and don't do a proper collateral assessment or a dial test, then you will end up fixing your LCL in a slightly loose pattern. Every time they're walking, they're doing that basically. They're doing a varus thrust because the LCL is loose. And the more you do that, the LCL is over there, it's going to end up stretching and stretching and stretching until it fails. It's got a 3 times more failure rate. So I've picked up 3 in the last 12 months of people who listed it, and I've caught them on it before examination with them. So good, I put it twice there. What's this? What is the Gone fracture? We mentioned it a couple of times, but no one's actually said what it actually is. What is it? Just shout out loud. Yeah, so what particularly about catch capsule? The anterolateral ligament. I know I mentioned the name a lot, okay, because Andy taught me a lot, okay, but he doesn't believe in it. He thinks it's a myth. But obviously there is something that attaches here, because whenever the ACL ruptures, what's happening is the knee is subluxing, okay? So what do you get on MRI scan? Pivot shape breathing. Why do you get that? I'm looking at you now. I don't know your name, but Russell.
At least the lateral tibia, the lateral femoral condyle hits against the heel tibia or the other way around.
Yeah, so the tibia moves forward, right? Okay, so it ends up moving forward, it rotates around, it stretches the entire lateral side of the knee. So that's why you get PLC injuries quite commonly with it, because if you stretch the entire lateral side, the ligaments on the outside get across it. At the same time, you can pull this ligament on the outside, the ALL, which then gives you that fracture. But then your femoral condyle is abutting against the back of the tibia plateau. That's where you get the pivot shift bone bruising, which is pathognomonic of a ACL injury. Axial imaging is so underrated. It's the first image I look at an MRI scan, and here you can see everything. Okay, PCL's over here, and then oops, big gap where the ACL should be. The ACL comes all around the back around here. Should attach there. There's a big gap there, so that's an ACL rupture, quite a high one as well with it. But you go down, you can see the patellofemoral joint, you can see the menisci, the condyles, you can see everything. So it's the first thing I look at. I then get the sagittal and the coronal side by side, and then here you can see that classic pivot shift bone bruising. Because what's happened is this tibia has subluxed forward, and that has kissed the back of that tibia, giving you that pivot shift kissing lesion. And similarly, you see this here as well. You'll also notice that most of these injuries will also have a deep MCL injury. It's a very underreported thing. That's one of the reasons why, you know, I will report the scan and look at it myself, then check the report, and normally they've missed out a couple of things. So two things I always miss is deep MCL injuries and ramp lesions, because they don't look for them as often. Whereas if I look for them, because I'm used to seeing them, I'll ask them to go and change it and add that in, because most of the time it will be there as well afterwards. So with any condition you treat, you have to think about natural history. Is your intervention going to change the way it goes? So when someone says to me, my ACL is gone, I want it done so that I don't get OA, that's bollocks, okay? Because it doesn't change anything. The reason to do ACL surgery is to prevent pivoting and to give them more stability. So it's called, that term, functional stability. Your risk of arthritis still goes the same way with it. You can't stop that. It's happened. The game is done with that. What you want to be able to do is reduce the risk of meniscus and chondral injury and prevent them from getting any pivoting. So in Coventry, they discussed this rule of thirds. A third of the patients you see will cope with them. A third will have symptoms but won't cope and then come to you later. But a third of them won't cope at all. And they're the ones you want to tackle straight away. And we know that if you delay ACL reconstruction, that the risk of chondral meniscal injury goes up with it, especially in kids. So that is the reason to try and do ACL injuries, ACL reconstructions earlier. I think maybe out of the last 50 I've done, maybe 1 or 2 of them I've done as isolated ACLs, just pure ACLs. Otherwise, every single one of them has had some sort of meniscus work, chondral work, or an LET, something to help do something else with it. So we've gone past the days of now doing a straightforward 20-minute ACL, which the old guys used to do. This is crucial, and I think it's a big message for everything you do out there. Okay? This is the first letter in my first line of my letter when I discuss managing anything with anybody. All my letters are dictated to the patient, so that RCS guidelines are you dictating to them. So I would say we discuss management options today, which include doing nothing, physiotherapy, or surgery, because they are the valid options. Okay, that's Montgomery's rule. You must give the patient all the options, because kids may not need nothing doing. You know, the banker who works and gets pissed on a Friday night, who's 40 years old, doesn't need an ACL maybe. But your 18-year-old footballer who's going to go to uni might need it doing. So actually, you've got 3 scenarios where you think you need to do that. And if you don't say this to them, and something happens, then they can sue you saying, well, I was offered that. I did surgery because that's what I was told to do. So that's the line of everything I discuss with it. And it's really important to cover yourselves because we're going to get sued soon. All of us. So how do you manage it? Well, 2 big papers that you can quote. The old style paper was by Frobel in 2013 from the BMJ. He basically showed that if you treated ACL injuries, actually over 5 years, they were fairly equivocal with outcomes with it. But actually, what we know from the SNAP trial is that patients which is the most recent trial that's come out in the last couple of years, this was a pragmatic multicenter trial. It showed that patients were split into 2 different groups, physio versus surgery, and they showed that there's a lot of crossover. About 45% of them went from physio to surgery. And actually, the ones that did go have surgery were more cost effective in the long term, even though the initial cost was higher, but they had less injuries afterwards and less complications afterwards as well. So actually, if you see a patient who is most likely for an ACL candidate surgery, just get on and do it. The ones that who aren't sure about are the ones who I think, I'm not sure if I'm going to go back to sport yet. So they're the ones I give physio for a few months, then come back, try sport, but they always come back thinking, I'm sorry, it's still not working. So I give them an ACL. And we know it trashed the rest of the knee with no ACL around. Repair, we've discussed it. I'm not sold in it, so I'm not going to discuss it. But a reconstruction, it's reliable, it's predictable, and it's protective. And that's the mantra, which is why we do it. Now, I have to give credit to Andy. This is basically his slide, okay? But he has 7 steps to make ACL surgery easy. You must choose the right patient, which we know, because if you don't choose that patient, if things go wrong, then it's going to be a disaster. You must choose the right graft, so it depends on the kind of patient you're treating. We can discuss that later on. You must put the graft in the correct place. If you don't fix it in the correct place, the most common cause of revision surgery is due to malplaced tunnels. You must fix it correctly. It could be with a screw or with a suspensory button. And then more commonly, you've got to minimize those ACL stressors. So we know that ramp lesions, root repairs, osteotomies, or LETs, these are things that have changed the way we treat ACL injuries. As I said earlier, it used to be a 20-minute operation. We're now looking for other things to help. When someone comes for a revision ACL, we think about what has caused that ACL to fail. Most of the time it's because the surgery was done badly, but actually they could have other things going on. They had a missed ramp lesion, they may have had a root lesion, they may have had a massive slope or massive varus, a missed PLC injury. You must avoid infection because an infected ACL is a disaster. I mean, touch wood, I have not had one yet, okay, but you know it will happen once you get a few cases under your belt. And good rehab. You know, you heard John Green at Lippman Castle. You know, a good physio can make it look really good, but a bad physio can make it look really bad. And it's so important. I even encourage my patients to try and get physio privately for the first 6 weeks. To say you won't see it on the chest for another 6 to 8 weeks. So worth having a session for the first 6 weeks with a private physio if you can, because otherwise you get stiff. The extra bits, okay? So this is the bucket handle of a case that I did, and it was a disaster. You know, I think there was a lot of swearing in that room that day. I remember throwing some things, de-sterilized scope, all that bollocks. You know, yeah. I had a tough day that day, but I had to repair it. It was an 18-year-old. Okay, so there's a big bucket handle. It was quite old. You can see these are rolled edges around the end of the meniscus with it. Talked to Chin earlier about this with it. They're the kind of patients you say you wouldn't repair with it, but I could not chop out an 18-year-old meniscus. So this is inside-out repair that I've done with this guy all the way through, and that will give a good stability because I've improved joint congruency, like Imperial talk, but also it's got a higher rate of healing with an ACL reconstruction at the same time. I mean, there's different, you know, back in the day, it used to be 2 grafts, right? It used to be a hamstring or a BTB. We've now got other options now. We've got quads, we've got peroneus longus, we've got RecFem, which I learned last week, and allograft as well, which we'll come to later on. So what graft are you going to use? Well, BTB, I think is the best graft out there, okay? It's gold standard. If you look at the Kaiser Permanente data out there, it's got the lowest revision rate when it comes to any data. Kaiser Permanente is an insurance company in America. They compared all the ACLs done over the last 20 years, and they showed the lowest revision rate compared to hamstrings, because hamstrings do fail versus BTB, isolated though. So it's the go-to bone block. It's the go-to graft for footballers or professional athletes. You know, it's bone-to-bone healing, so the idea is that actually you'll get quicker incorporation of the bone, you get quicker healing, which means that you will get faster recovery. Also, it's a large square peg in a round hole, so it's not going to move around, so it's more stable. You use screws as well with it. But we haven't done, I mean, we'll come to it in a second about the trials. In a recent ESCA and ISKOS vote, hamstring was the commonest graft in over 75% of surgeons. You know, it's a huge deal, okay? Hamstrings are easy, all right? It's the commonest graft. You know, you can use it because it's quite malleable. You can triple it. You know, the common way is doubling it over by an ender button. You can triple it. You can quadruple it. This is my hamstring graft. I get one hamstring and I quadruple it around, so it gives me a really thick, short, stiff graft, which I like because I use a double suspensory method. Quads, I've done it a couple of times. So if I had been asked what my graft choice was, it'd be 50 hamstrings, 40 BTB, and 10 quads probably. I'm not sold on it just yet. I've used it only in a kid or in a revision case. And then we've got other new things coming up, peroneus longus and RecFem, which I haven't got any experience in at the moment, but I hear good things so far. But you know, with ACL surgery, you know, you're always pushing the boat out with something. There must be some money being made there. You know, Mr. Guthrie talked about allograft. You know, I agree. In kids, it is far superior to use autograft, and the Mars data showed that in their study, where it was almost 3 times higher rupture rate in kids or in adolescents using allograft versus autograft. But allografts are coming to fashion, and there are a couple of reasons as to why allografts fail. I mean, first of all, they're being prepared incorrectly. Okay, so every graft is getting irradiated, so they have loads of gamma radiation going into it, weakens the graft, and that's one of the reasons that things have changed recently. So allograft, especially from the company I use, they're low radiation. You know how grafts are prepared? They go through all, Rishi Deers talk about how they do it. You have to be screened properly, prepared. What's his anagram, acronym he learns for it? Yes, smash or something like that. There's different phases of how you go through it. No, DUIs, I think. Debride, ultrasonic, DUAID, debride, ultrasonic wash, ethanol, antibiotics, irradiation, and demyelinization. But that's changed slightly with allografts, all right? We're using low radiation, so that's changed the way that grafts are now being used. So they're actually a lot better than they used to be. And data now is showing that actually the erosion rate is pretty much the same in like the over 40s compared to autograft with it. There's a nice graph, couldn't find it last night, but Pete Thompson's got a great slide where he shows a graph showing the rupture rates in age. And it's really high with allograft, but then actually over time it plateaus around 38, 39. And then after that, it doesn't really matter what you use. The idea is obviously I think I use it a lot in multi-leg settings. So when I've got a multi-leg, rather than taking another autograft and weakening them, especially in an athlete, I use an allograft there, especially if it's extra-articular. I'm less so on intra-articular potentially. But also, you get really bulky, thick grafts coming out of it as well. So it's quite a nice way without damaging anything else that they've got inside their knee. One of the most painful things that patients find is the harvest sites. They find it really hard to kneel on the BTB or really hard on the sites where the hamstrings are. So I think allografts are coming into fashion slowly, but I think we need to be careful how we use them, especially in the age groups. When I do a hamstring harvest, I always do a oblique incision. So you always talk about 4 finger breadths below the joint line. I hate signs like that because my fingers are different from your fingers to your fingers, okay? But actually 4 fingers is pretty close actually. But in thin people, you can feel the hamstrings. So near the tip tab, you can feel the pes going up and down. And that's what we're feeling here. So I use a oblique incision. And for the reason that Andy's described here, these are his pictures, where you're looking straight down. You can see all the way down the tunnel of the adductor canal. What are the layers of the medial side of the knee? Somebody? Abby? I don't let anybody harvest the hamstring without telling me that answer, and Primal knows that. If I ask him that, you better fucking know the answer.
Skin subcutaneous, your answer.
No, forget that, mate. Okay, like a proper A-level answer. What are the 3 layers of the medial side of the knee? What's the first layer you see when you open the skin and the fascia? You get this sort of shiny sort of substance. Above the pes. Sartorial fascia. Yeah?
Yeah.
And you nick that sartorial fascia, and then you'll see the hamstring just underneath it, like just touching up against the fascia. What's the next thing you see? The really shiny thing going behind it there. Anyone? Superficial MCL. And then the third one is your deep MCL and capsule, all right? There's the same thing on the lateral side of the knee as well, but we'll come to that later. But see, once you nick that sartorial fascia, what I tend to do is pull the fascia forward. I make sure I can see both tendons first, and then split the fascia down the canal, and you can see the whole tendon then afterwards. What's this?
Vinculi.
A vinculi. What's a vinculi? It can have a supply to it, but I think it's either Greek or Latin for chains. So you get these chains that are attached to other parts of the fascia and the hamstring with it. What's the big deal about these? Why are we obsessed with them?
Off when you're doing the graft.
Why?
Don't take them off or prematurely amputate your graft as you're trying to harvest.
That's one of the things, yeah, but it strips it down basically. So if you imagine this vinculi here, if you didn't cut this vinculi off and you put your stripper down and that was attached, then you would end up stripping all of this hamstring down here and you'd lose half the hamstring with it. So a lot of people who harvest hamstrings incorrectly and get really skinny grafts, it's because they haven't got a vinculi potentially. And there's always a big fat vinculi on SEM-ET. That's how you know which one's which. So you always grab the vinculi. So I always have 2 Leahys on my set, and I have 1 Leahy to pull the hamstring out. I have the other Leahy to go down the side of the. I started off. The hamstrings here. I start it horizontal, come down, then come backwards and pull, and whatever comes forward, I then cut to make sure I've got all the vinculi. I can then use arthroscopic hook as well to go all the way down, and that way I know I've got the vinculi with it. Bearing in mind I've still stripped 1 or 2 because we've missed them quite high, but it gives me a better chance of catching them doing that method. Very important to get tunnel position correct. Okay, it's, as I said to you earlier, the Mars data showed that about almost 47% of patients who had revision surgery had it due to tunnel malposition, and a lot of that was in the femur. So we're obsessed with femoral tunnel positioning. So everyone started off doing AM bundle, going right to the back of the femur to go put it there, and then people started going more central, the anatomic to go in the middle. Actually, it showed to be quite a high failure rate, and Andy admits that it was quite a high failure rate. He almost doubled his failure rate with it. People started doing double bundle, which 33 pioneered, which also didn't have that great results. We're now back here. I think this is the most reliable way of doing the ACL, which is where I was aiming for. And we tried to reproduce this at the Wexham meeting, where we tried to get surgeons to put their tunnels versus where they wanted to put it, and realised a lot of surgeons were missing where they were putting it because they didn't know that was where the positioning was. So it's quite interesting to see how your perception versus actual coming out with it changed it. Your tibia is just as important as your femur, and I think tibia is overlooked. A lot of the cases that I've had to revise, or certainly revised in Coventry, were due to very different tunnel position, but it's very anterior. So it's very anterior. What's the issue that can happen? Hindrance, so they basically get a guillotine effect of the graft. It's very posterior what happens.
Hinge on the PCL?
You can extend.
Vertical ACL, which is
Yeah, it's very vertical, so they're actually just rotating around, so then they can pivot off it as well. So the rule that I use for it is, if this is once again the ACL study group who did a study to look at where the tunnel of it was and where people were putting it, and they did the same thing again. They first asked people to put their tunnel where they want to put it, came back the following day and asked them to do it again, and there was massive variations where they're putting it, and this is between consultant surgeon doing it for 10-15 years as well. But the consensus that I was always taught was using the anterior horn of lateral meniscus halfway between the medial tibial spine, and around there is where the footprint is. And you'll always see the ACL footprint, because remember, it's that broad cylindrical substance that goes all the way around. It's got a wide footprint. So I didn't take down the whole footprint, as one of my old mentors, Andy Pearce, said to me, God's given you a map, use it. So use the footprint and put it in the middle of that. This is an example of landmarks. So we actually asked an interesting question about where people use their landmarks with it. This structure here is called the apex of the deep cartilage. It's the posterior condyle cartilage. That's what I use as my landmark to be able to put my tunnel and use that as my reference point on the height. And I actually wrote a paper with Tim about using this guide that helps you identify where that tunnel point is. And actually that's a very accurate place of putting it for your femoral tunnel in that position. You use that position as your guide for height. How are you going to fix it? So suspensory versus screw. I think most people, traditional ACL is a button screw technique. I worked for 2 surgeons who did both. So Simon used to use a double suspensory and Andy used to use button screw. Advantages, suspensory, you've got something that is hanging off the edge, cortex doing all the work for you, and then you've got this big screw that ends up going inside and holding it nice and long. I prefer double suspensory for the reason that I use a short stiff graft, quadruple it. You have to be careful not to bottom out. For me, it gives me the opportunity to be able to get all the creep out of that hamstring, because hamstrings do stretch, they're viscoelastic. You've got a shorter graft. If you imagine getting a elastic band, you stretch it from far away, you can stretch easier. If it's closer together, it's got less risk of stretching. And with the suspensory system, which you'll try out later on today with Ultra Button, you can really crank out as much tension as you can do, but you have to worry about your effect of cheese wiring the graft. So I've got a very particular anal way of preparing the graft, which makes it avoid that situation. You can use different ways of fixing the graft. You can use screws, non-absorbable or bioabsorbable. I use metal screws when I'm using things like BTB, because I think that first of all, they're reliable, they're cheap, but also they've got good hold, and I can see them on X-ray quite nicely, because I like to get an X-ray after all my ACL, so I can appraise my tunnel position to see where they are. you know, Smith & Nephew do make peak screws. They're quite expensive. I'm not really sold on it yet. But once again, I like to see them in X-ray, which you can't really do with peak. Bioabsorbable, there are these implants that they sell which, you know, claim to be able to reabsorb within bone after a year or so. But in my experience, I've never seen them absorb. They always come out in revision surgery. And they always cause sometimes lysis and tunnel widening, which makes surgery quite difficult. And occasionally I have seen them spin the graft around as well. They're also quite expensive. So I've got some mishmash videos to show you what the steps of it are. So when you've got your tunnel position, you drill the femur first. So this is using ender button technique where we're drilling using a guide wire. And this guide wire is your pilot's guide wire where you put it through the center of the hole you're going to put it through. Now, there's two different ways of doing it. This is a normal 2.4 guide wire. You can use that as a way to measure your tunnel, or other companies have these spade tip where you can hook onto it and grab it. The old way of doing it was drilling it, taking it out, measuring it, go back again. You want to work out what your tunnel depth is. Once you've worked out your tunnel depth, you then start drilling your actual tunnel size, depending on how big the tunnel is on your graft. That's the same video actually, isn't it?
What's the recommendation of the tunnel length for femur?
Depends on the size of the patient, the height of the patient, but it's on average between 35 and 40. So, you know, without being sexist, women 35, men 40. If it's less than 40 in a man, I'm worried about probably a bit too posterior, because you're drilling it and the shape of the femur, you're drilling it at the back of the femur upwards. If you've gone a bit too posterior, then you're hitting on the back of the cortex with it. So 40 is my way of realizing I'm trying to aim for the middle of the femur. If I'm too short than that, then maybe I've gone a bit too posterior. But it depends on your length of what you're using as well. So ender button versus other things, they're very different as well. Once you've drilled your tunnel, you then put one of these sutures through there to be able to mark it out. You can see this is actually a revision case. We filled it with some bone graft up here with it. You then use that suture as a way to part your graft a bit later on. Annoyingly, I haven't got a video of me drilling a typical tunnel, which is so upsetting because I talked about how important it was
So
earlier.
they've got it on their video. They've actually got a video.
Oh, have you? Okay, great. This is just passing the graft up. This is the ender button going up with it. Now, someone talked earlier about the fact that sometimes the buttons don't ever flip. I use a system with another company, so I actually watch the button go up the tunnel, and then I watch it flip out. If I know I'm down, I then pull it back down again, so I know that I've flipped all the way up with it. So I've never had to open up or worry about the fact the button hasn't split, hasn't slipped. But with ender button techniques, to pull it all the way up, and you feel it give, you then toggle it, do it again, toggle it, and then you pull back down on it again, which you can show have a look later on here as well. This is an example of a BTB being pulled up with it. BTBs are tricky, and I always regret doing them when I'm doing this kind of part of the operation because it's so fiddly. And it takes a lot of patience, and I can't. You know, the worst thing is that they pay the same money. They pay the same amount of money for doing a hamstring as a BTB, but it's like twice the stress of doing the same operation with it. But they look and feel a lot better, which is why I like doing a lot with it. And I won't get this video too long with it, okay? But the idea of this is showing you that the graft goes up, you have to navigate it around, and then you fix it back with a screw. And the idea of the screw, sometimes you've got to make sure the screw is positioned properly with it. I love these screws quick start because they actually are quick, easy. They spin the graft very easily with it, and they go in really, really easily. We touched on it earlier about how you augment ACLs, and the big thing in the last, I think, 5 years for most knee surgeons has been the LET. Basically, it's been around for a long time. Mr. Gupta was telling me earlier that he's saw it almost 20 years ago, and even someone like David Dandy in East of England was doing this years ago. The French were doing this for years, and so the Belgians, but they kept it secret until it then came out as a big thing. But the way that I describe this as to patients is it's like a double ACL. Okay, it's your check rein on the outside of the knee to stop anterolateral instability, because we know you've stretched the outside of the knee, so having something to augment it on the outside gives you that double effect. And if you look at an MRI scan of an LET graft with an ACL graft, if you've done it properly, they'll be parallel to each other, so they will actually work the same way. And I've seen a patient who landed awkwardly, jumped on it, the LET had popped, the ACL was intact, so they actually had protected it in that manner. I mean, the big thing that came out 5 years ago was Al Getgood's study on stability trial, where he showed that it reduced your rupture rate in single bundle hamstrings with an LET by almost 50%. It went from 11 to 4%, which is quite a huge thing. So there's still debate on who should do it on. If you ask some surgeons, they say they do an LET in every single person. I think that's a bit wrong, potentially. Not everyone needs an LET. The risk factor they identified in the paper here with these groups here, people who had an explosive pivot, who was more than grade 2, anyone who went back to a pivoting sport, if they're younger than 25, and anyone who's got generalized ligament laxity. And we've extrapolated that to another cohort of patients, which is a redo ACL surgery. So all the revisions get an LET now as well. But there's quite a controversial thing about doing it in older patients who've got some lateral compartment wear, because are you potentially accelerating some wear in that side of the knee? You know, Andy's done loads of studies on it to compare that actually biomechanically makes no difference whatsoever, but the long-term data on it suggests they may do. We don't know yet. So where do you fix it? Well, I won't bore you to death about this, okay, but it's got to be isometric, okay? So anywhere along this point is completely fine. The way that you do an LET, very quickly, is you mark it out. It's an incision from the epicondyle to the Gerdy's tubercle. You're incising it to be able to identify your IT band, which is the first layer on the lateral side of the knee. You split it down the middle, and then you want to take a 1 centimeter strip from the IT band. The way I use it, I use the back of my forceps, which is about the same distance or the same width of that tissue graft. You keep it attached to Gerdy's tubercle. You then harvest it, you leave it to one side. I mark the top of it and leave it out to the side of the lady. You then want to find the LCL, and this is the LCL. It's this tiny piddly structure on the outside of the knee. The way to feel for it, you look, it originates from the lateral epicondyle, inserts in the fibula. If you're unsure, you can go to figure 4 and it tightens up. And then there's various ways of doing it. So the way I started doing it is with an anchor. You put an anchor down, and then you pass your graft under the LET, your LCL. The LCL acts as a fulcrum to be able to anchor up against it. And then I use a suture anchor as a way of doing this. So suture it down and cinch it. The way that Al Decker described it in the trial was with a big staple. The problem with this is that obviously this is at the epicondyle. Your femoral tunnel is coming around here somewhere. There's a risk of converging your ACL tunnel with your LET tunnle. So a lot of people will end up going very proximal up here, so that you're proximal to your button. There's no chance of intervening it. You know, I aim mine in a way that I don't ever converge with it at the moment. So I'm being a bit safe. And then, as you can see here, it stops that. It tightens up in anterolateral stridus of the knee. Big thing is prevention. Okay, it's huge at the moment. Kate Webster's done loads of data on it to show that you can reduce the rupture rate of ACL in kids and females by up to 50% if they go through a really vigorous program. And the big thing that we're pushing in the UK in BASCA is the power to play, where kids, you know, you've got ambassadors going to schools and kids and preparing them to do this thing called the warm-up to try and protect their ACLs. And this has come off all from this, the FIFA 11 thing, which is what FIFA have advocated for young athletes to be doing. So we're now in the end, thankfully. I think it's imperative that you understand how important your examination history is when it comes to diagnosing these. As I said earlier, you know, I know what they've got wrong after they've got off the table. The MRI scan just confirms my diagnosis, but also it just shows me other sides of the knee that I haven't been able to examine, like the cartilage or meniscus that can tell me this. You know, always treat the patient, not the scan, okay? Because they may have a torn ACL, but they don't need an ACL reconstruction. Okay, you discuss the options with them. And as long as you stick to principles, minimize stresses, keep isometric, you will have a successful ACL reconstruction. Right. Thank you.
Thank you.